Good afternoon, everyone. Welcome to our 12th extension of Community Health Outcome session. Just a brief reminder before we start the introductions. We need to make sure our phones are on silent and we mute ourselves. So last week we had a case on TLD transition, which was for an elderly lady, 79 years old, who was on tenofovir, lamivudine, and nevirapine. We agreed to actually transition this lady to TLD because she's above the childbearing age. We want to welcome everybody that has joined us, but for the sake of time, I'll just mention your facility, then you can wave. That will just make sure that we are able to hear each other. So, Lewanika, are you able to hear us? Lewanika, Howard and Tim, we can see you. Are you able to hear us? You are welcome. I hope you can sort out your sound. It's clear Lewanika can't hear us. I see we have somebody from Monze. Are you able to hear us? You are welcome. Okay. Okay, then we have Chilenge Hospital. I see Dr. Onoya. Are you able to hear us? Okay, I see your hand is already up. Amazing. That's fast. We have the team from Minga Mission Hospital. I hope Minga can hear us. We can just wave if you can hear us. Okay, perfect. We have Nangongwe, Kafue. I see Dr. Mwape and Nathan. Okay, perfect. Petauke. Are we able to hear each other? Okay, awesome. Then we have Senanga District Hospital. Unfortunately, you've just lost your video. I hope you can hear us, Senanga. Please wave if you can hear us. Okay, they can not hear us. That's a bit worrying. Okay. For Livingstone Central, I can see you've joined us. I hope Livingstone can hear us. Please wave if you can hear us in Livingstone. Okay, that's fine. I saw Chipata General Hospital. I hope you can hear us. Okay, among the people we are joined by Dr. James Simpungwe from CDC, Dr. Maria Tonga, Dr. Loti Hachambwa, and we are joined by Dr. Chitalu, who's one of our panelists, Dr. Daniel Ba, of course we have Dr. Albert Mwango, Dr. Jeanette Okoye, and we have Dr. Islam. Dr. Islam actually works in Chaisa. Sometimes I go there to do consultations. Okay, Dr. Mukuna, can you hear us? I know you're joining us from Mundazi. Okay, perfect. And we have Jim Yunda. It's nice to see you again. You're with us last week. Hope you can hear us. I would like to encourage everybody in the network to turn on their videos because we've seen a lot of people have their videos off. It's actually even difficult to know if you can hear us. We encourage you to turn off your video unless you have an internet issue. That said, in the hub, we have the ID team. We are joined by our colleagues from the University of Maryland. And we also have our HIV nurse practitioners. This is a huge program in Zambia. I know in June, we'll be enrolling more students to this program with the support of HW21. And now we have Dr. Claassen Cassidy, one of my personal mentors. He knows everything about PrEP. He's going to talk to us about PrEP today, then we'll go to the case. Our case for today is coming from Mongo. It's being shared by Precious, who's a clinical mentor. So we'll go ahead and share his slides, but I'll ask Dr. Cassidy to say one or two things.
Good afternoon, everyone, and hello to all of Zambia that I'm speaking to today. It's a great privilege and an honor to be speaking with you all today, so thank you for inviting me, Dr. Filoshi and the ECHO team. My name is Dr. Cassidy Claassen. I'm an assistant professor at the University of Maryland. I've been based here in Zambia since 2015. And I've had the privilege of working with the Zambian ART Technical Working Group on leading development of PrEP policy in Zambia. And so it's for that reason that I've been asked to present the guidelines here today and then discuss this very interesting case that's been brought forth to us. So with that, let's get started. The first, next slide, please. So the learning objectives for today are to, first of all, go over the recommendations for universal precautions, and then identify clients who are eligible for PrEP. So we will review the Zambia Consolidated Guidelines and the eligibility criteria for PrEP, who should go on it, and then for number 3, we'll discuss the recommended workup and timing, basically how you go about monitoring a patient who's on PrEP. So I've put a few cases throughout here to prompt discussion. So this is the first one. If you're in the clinic and a nurse is about to go draw blood on a patient, and everyone knows that this patient recently tested HIV negative, and she's about to go and start to draw blood without any gloves. So what do you tell her? You say that since the patient is known to be HIV negative, there's no worries and she doesn't need to use gloves, or option 2, that she should wear gloves when collecting blood on all patients, no matter what their HIV status is.
Okay, somebody to answer that?
Sure.
Okay, so Dr. Onoya, I'm sure you've seen the question. I know you have good sound, that's why I'm picking on you, so that we don't waste time on this. What's your take on this?
I think the patient should wear gloves, the nurse should wear gloves when collecting blood.
Please speak up.
We go for the second option. Second option. You should wear gloves when collecting blood on all patients.
Yeah.
Okay, Dr. Onoya says that they should wear gloves on all patients, whether HIV positive or HIV negative. Any comment on that, Dr.?
No, that's exactly correct. So this is just to lead us into the discussion on universal precautions. So this talk is really about various methods of HIV prevention. And so in discussing universal precautions, this is relevant to HIV prevention in the hospital. And there are 5 key steps of universal precautions. Education, that's first of all making sure that all of us as healthcare workers understand the need for being cautious with all patients. Hand washing, so as we know, hand washing is one of the greatest, most single important thing we can do to prevent infection between patients and to ourselves. Use of personal protective equipment, so this is gloves, masks, gowns, eyewear, and each one is relevant in certain situations. And so it used to be once upon a time that we tried to gauge whether we needed to use this or not. But anymore, we state that we use PPE for all patients as relevant. We clean all contaminated surfaces, so every hospital should have a plan in place to decontaminate all surfaces in the hospital so that there's not infection. Remember that certain pathogens, such as hepatitis B, can remain infective on surfaces for a long time. And we handle and dispose of all contaminated materials safely. That includes needles, sharps, any potentially contaminated material. Next. So, this is one more question for you also. Here's a healthcare provider who appears to be drawing blood. In addition to wearing gloves, this is also wearing a mask, a mask and a head covering. So true or false, masks and protective eyewear should be worn whenever gloves should be worn.
Hi, Nathan from Nangongwe. Are you able to take that up? Is that a true or false? What do you think?
Yes, no, I'm hearing. Here with the team, we're saying it's false.
Okay.
All right, and you are correct. We can move on. So gloves should be worn whenever you're touching blood or body fluids or non-intact skin. But really, also for a procedure such as venipuncture, anytime you're going to be coming close to blood in any way. But masks and protective eyewear are only needed during procedures that are likely to generate droplets, either droplets of blood or other body fluids. So things like CSF or during surgery, things like that, then it's necessary. So just for a routine blood draw, we don't need to wear masks and protective eyewear, but they are needed for sterile procedures. Okay, moving along. We'll come now to polling question 1. We're going to discuss, this gets us to the rest of the discussion, so I'll read it to you. A young pregnant woman comes to clinic for her first ANC visit. She has tested HIV negative. Her partner refuses to test, but she is worried he is HIV positive. Her partner also refuses to wear condoms. What options for HIV prevention can you provide her with? Option A, education. Option B, education and condoms. Option C, education, condoms, and PrEP.
Okay, so we only have 2 people responding, which looks like 100%. Okay, we have, I think it's C. Okay, we'll discuss the answers later. Okay, please keep polling. Okay, okay. Oh, there's education and condoms. Okay, thank you very much.
Okay, so this leads us to our discussion. So what is PrEP, first of all? So PrEP stands for HIV pre-exposure prophylaxis. So what this is taking 2 antiretrovirals every day to prevent acquisition of HIV. The 2 antiretrovirals that we recommend for PrEP are tenofovir and FTC, so that's commonly known as Truvada. You see a picture of Truvada there. The combination pill, and this is important. This is not taking ARVs when you have HIV. It's people who are HIV negative taking a pill every day so that they don't get infected with HIV. And so it's similar. We use prophylaxis in different scenarios in infectious disease medicine. One common area is malaria prophylaxis. So many of the Americans who come to visit me here in Zambia, I suggest they take malaria prophylaxis if they're traveling in Zambia, and that they don't have malaria already. They're taking a medicine to prevent getting malaria. And so HIV is similar, or PrEP for HIV is similar. So does it work? The answer is yes, if you take it. So there's up to a 92% reduction in HIV acquisition in randomized controlled trials. Actually, in real life, this has gone up to 99%. However, the efficacy is 100% correlated to adherence. So just like most medicines in the world, they only work if you actually take them. And here I've mapped out for you, this is the results of 6 different trials on PrEP. And what we see here is that when adherence is on the y-axis, and as adherence goes up, protection against HIV also increases. So the lowest were the FemPrep and Voice trials, which were done in Botswana and Uganda, and people took the PrEP less than 30% of the time. So it didn't work at all. But at the upper end of the trials, when people took the medicine over 95% of the time, it worked almost 100% of the time. So it really does work if you take it as you're supposed to. And we'll talk more about that a little bit later. So next, who is eligible for PrEP? Basically, to summarize our HIV guidelines in Zambia, there are four key elements. So they have to be HIV negative, they have to be willing to be adherent to the medication and also to follow up, and they need to be at significant risk for HIV acquisition. So people who are HIV positive are not eligible. People who don't want to take the medicine or don't want to come see you in clinic are not eligible. And if they're at zero risk for getting HIV, then but even if they want it, it's not necessarily a good idea. And then also, it's not critical, but we also think about members of key populations for this as well. And we'll talk about that in a minute. So going to these more details, this is from the 2018 Zambia Consolidated Guidelines for HIV and antiretrovirals. And so this is our PrEP eligibility criteria. You must have no suspicion of acute HIV infection. You have to have a recent HIV negative test. You have to be interested in PrEP and willing to be adherent, and that's a key element, that they're willing to be adherent. And they're able to attend regular 3-month reviews. So one of the key things about PrEP is that it's important that people do not become infected with HIV while they're on PrEP. So if they're taking it not like they're supposed to and not coming to clinic, they have a chance of then acquiring the virus and not taking the medications properly. Because then if they're actually becoming HIV infected and they're only on 2 ARVs, it's suboptimal therapy and it could lead to resistance. They should be able to use other prevention methods, such as barriers, that usually means condoms, to prevent the transmission of other sexually transmitted infections. And they should be able to stop taking PrEP when they're not eligible. The second round of criteria defines the risk factors. So they need to be at substantial risk for HIV infection. And the Guidelines Committee defined that as engaging in at least one of these activities in the last 6 months. So vaginal or anal intercourse without condoms with more than one partner, sexually active with a partner who is known to be HIV positive or who's at substantial risk of being HIV positive, a person who's sexually active with the HIV positive partner who's not on effective ART, and that means an undetectable viral load, history of sexually transmitted infections, history of PEP use. PEP, as you know, is for post-exposure prophylaxis. So people who have been exposed to HIV and had to use PEP in the past should consider PrEP if they're going to have repeated exposures. And then people who inject drugs, sharing injection material or equipment. Next. And finally, in the guidelines, it also states that it may be considered for key populations that are as defined by the 2017 National AIDS Strategic Framework, or anyone who is self-selected as high risk for HIV acquisition. So just to review, the NACF 2017 identifies the following key populations. People living with HIV, well, I've graded that out because those people are not eligible for PrEP because they should be eligible for ART, but everyone else could be considered. That includes adolescent girls and young women, young men, inmates, migrants, people who inject drugs, sex workers, men who have sex with men, transgendered people, children and pregnant women, displaced persons, persons with disabilities, and people aged 50 years and older. There are many key populations in Zambia. So moving on, we get to the next polling question. I'll read it out to you. So a young man who has multiple sexual partners and does not always use condoms has come to your clinic for PrEP initiation. What labs are indicated at the first visit? Option A, none, start PrEP right away. Option B, HIV test only. Option C, HIV test and serum creatinine. Option D, HIV test, HIV viral load, and serum creatinine. Option E, HIV test, serum creatinine, ALT, RPR, and Hep B surface antigen.
Okay, we'll wait a few seconds to see what's happening. We only have 4 people. We expect at least 10. Okay, so the answers that are coming up are HIV test only before you start PrEP. There are people who are saying you need to do an HIV test, an HIV viral load, and serum creatinine in this HIV negative person who's about to start PrEP. Then a good number, about 85%, feel that it should be an HIV test. You need to check the kidneys, you need to check the liver, screen them for STIs, and also check for hepatitis B surface antigen. So we'll go back to those later. Thank you very much for all those that voted.
Okay, so moving on, we'll talk about how to initiate PrEP. So when a person comes to see you to initiate PrEP, the lab tests before PrEP include HIV tests. So we want to make sure that only HIV negative people are going on PrEP. We do check creatinine because we want to make sure that the kidneys are okay. People with kidney disease should not be on tenofovir. And if a creatinine is not available, then a urinalysis to check for protein can be done. ALT to assess the status of the liver. Though Truvada does not directly impact the liver, there could be some slight side effects, so it's just a safety lab. And then RPR, or that's not available, RST, so that's to check for presence of syphilis. Generally, people who are coming to you to go on PrEP are deemed to be relatively high risk for other STIs, so we want to take that opportunity to screen them. You should also do a clinical exam, including the genitalia, to screen for presence of genital warts or other STIs at that time. And a hepatitis B test is actually very important because if someone is hepatitis B infected, then you're putting them and you're giving them PrEP. The key thing is that we probably will continue the PrEP even after their risk for HIV acquisition is ended because they have an indication to treat their hepatitis B. And then the ARV regimen that we used for oral PrEP, as we discussed already, is TDF and XTC. So we can use 3TC or FTC. The evidence is slightly better for FTC as it does have a longer half-life, but either one is acceptable to use for PrEP. So there's some key elements of counseling and education for PrEP. PrEP only works when you take it. I think this is the most important thing. It doesn't work if it sits on the shelf. It has to be in your body, it has to be taken once a day, every day. People really have to adhere to taking it every day, and they also have to adhere to routine clinic visits. So one of the worst things we can do with PrEP is to put someone on PrEP and give them a 1-year refill and then walk away, because if they don't take it properly, they go in and out of adherence and they get infected and we don't catch it on an HIV test, then they could evolve resistance to the virus. Another key thing is that PrEP is not immediately effective. It takes some time for drug levels to rise to proper protective levels, and these levels differ in men and women. So in men, it takes 7 days to reach protective levels in the men, but it takes 21 days to reach protective levels in women. Why the difference? It's because the mucous membranes in men, which are the surface of the penis and also the foreskin, and also the anal area potentially, those are directly fed by the bloodstream, and so TDF levels reach therapeutic levels there very quickly. However, in women, the mucous membranes that are at potential risk there, particularly vaginal lining, there's more of a blood filtration effect. So TDF levels are much lower in those tissues. So it takes time to reach a protective level. So it's 3 weeks to protective levels in women. You can also counsel the patient that side effects are common in the first 2 weeks, but they are relatively mild, and after 2 weeks they go away. So they tend to be nausea, abdominal cramping, and headache. So then after you've initiated your patient on PrEP, how do you monitor them? Well, so we in the guidelines we recommend, so at the initial test 0, giving them making sure they're HIV negative when you start them on PrEP. They should come back at 1 month and then every 3 months thereafter. So at every visit, they should have confirmation of their HIV negative status with a repeat HIV test, and that is the most important thing. In addition, they should have adherence counseling and screening for side effects at every visit. In the first year, they should have creatinine checked at every visit. That's month 1, and then every 3 months. Thereafter, it can be done every year. The ALT can be done every 3 months and then every year. STI screening should be done every visit. Again, these are people deemed to be high risk for acquisition of STIs. PrEP drug dispensation, so we give them 1 month prescription at the first visit and then 3 month refills thereafter. And then counseling on risk reduction should be conducted every visit as well. When to stop PrEP. And this is one of the important things also, is that there's a bit of a paradigm shift from ART to PrEP. PrEP is a prevention mechanism. ART is a treatment. ART should be taken lifelong with perfect adherence for the rest of your life. PrEP is not that way. PrEP is for people who are at risk for the time that they are at risk. People may be at risk for a certain time in their life. For example, perhaps a young woman who's currently dating several partners, but then she chooses one and becomes faithful with that one person, and then no longer at risk. A sex worker who maybe crosses the border to engage in sex work for 3 months out of the year, but the rest of the time is not engaged in high-risk sex work and is not at risk. So we have to match the risk profile to the person and give them PrEP for risk reduction while they're at risk. But it's okay for them, when they come to you and say, I'm no longer engaging in high-risk activities, and they don't meet PrEP criteria anymore, they can come off of PrEP. So the way to bring them off PrEP, they can be discontinued when they're no longer at risk, and this situation is likely to be sustained. PrEP can be continued after 4 weeks after the last time they had sex, or whatever the risk was. That's just to give them as much protection, tail coverage as possible. Of course, if they have any side effects, or if their creatinine clearance decreases to under 50, that's concern for side effects from adverse reactions to the medicine, and it should be stopped. And then the other key point is that the positive partner has initiated treatment and has achieved viral load suppression. And this should actually read as an undetectable viral load. The negative partner on PrEP may discontinue therapy. And we're going to talk about that more in the case discussion soon. All right, so polling question number 2. A young woman has initiated PrEP. After taking her first pill in your clinic, she says, "Great, now I can have sex without any consequences." How do you counsel her? Which of the following is not true? A, PrEP does not protect against pregnancy. Is that true or not true? B, PrEP does not protect against other STIs such as syphilis and gonorrhea, only HIV. Is that true or not true? C, PrEP takes 21 days to be fully protective in women. True or not true? And D, one does not need to have any lab tests for PrEP. So please pick the one that is not true.
Okay, so we have the votes coming in. Okay, so a number of the individual doesn't need to have any reviews. They think that's not true. And 14% of the people in our network feel that PrEP does not take 21 days to be fully protective in women. I guess the catch there is they're not true. 90% now think that it's not true that an individual doesn't need to go for review for PrEP. A number of people feel that it's not true that PrEP does not protect against pregnancy. This is even hard for me when I say not true. Okay, yes. Okay. So remember, we are picking the one that is false. Which of these is false?
It's too confusing.
Yeah, very confusing.
Right,
my fault. Okay, thank you. Okay, those are the results.
All right, so this is key points to summarize. So first of all, universal precautions should be used for all patients. Next, patients who are at significant risk for HIV are eligible for PrEP. PrEP is highly effective if it's taken correctly. Proper monitoring of PrEP includes lab and adherence monitoring. PrEP takes time to reach protective levels, and these differ by gender, 7 days for men and 21 days for women. And PrEP only protects against HIV, does not protect against pregnancy or other STIs. Then I put one slide in here just to discuss some of the future of HIV prevention, because I think this is interesting stuff. So these are some of the key updates that were revealed at the AIDS 2018 conference this last summer in Amsterdam. We discussed the results of the Partners 2 trial and the concept of U equals U. If there's one thing I talked to you about for the future, it's this. This is very exciting. There's been mounting evidence, 4 different key trials now. HPTN 052, Partners 1, Opposites Attract, and Partners 2 trial that really demonstrate that when for serodiscordant partners, when an HIV positive person has an undetectable viral load, they do not transmit the virus. So this means if you have an undetectable viral load, you don't transmit. Undetectable equals untransmittable. So this is a key part of treatment as prevention. And I think this is an important message for all of us to really convey to our patients, to say, if you take ART, is it good for you and your health, but it's good for your partner and your community? You can be confident that if you are suppressed, if you're undetectable, you don't transmit. But we're done. And then there's a Prevenir trial which looked at on-demand PrEP, but this is only for MSM, so it's not relevant to heterosexual couples, but it showed that for MSM, on-demand PrEP equaled daily PrEP. But again, that does not work for women because of the 3 weeks to efficacy in the mucosa. There were results on dapivirine vaginal ring, which is exactly that ring shown there. It can be inserted in the vagina, and it dispenses a long-acting ARV that protects, that provides protection in situ in the vaginal mucosa, and it's shown to be about 2/3 effective. There are problems with adherence, But in post-marketing trials, phase 4 trials, it's looking about 2/3 effective. So an interesting, promising avenue for the future. Then we have long-acting injectable antiretrovirals. So the lead candidate here is one called cabotegravir, and this is an injection, and then it slowly dispenses ARVs in the body for PrEP. So once you reach fully effective levels, you would need to get a shot every 3 months, which I think will be very promising for particularly the youth community in the future. For young women, we can give them their birth control shot, their Depo-Provera in one arm, and their cabotegravir in the other, and see them in 3 months. It's an exciting opportunity for the future. There's also research going on subcutaneous PrEP implants, a little vial that you insert under the skin and it slowly dispenses. And then the holy grail is antibody protection. That's another word. That's another way of saying a vaccine. There were some updates on vaccine trials, but that's really over the horizon. We don't really have a clear. These other things are actually real and will be developed, in the next 10 years, 5 to 10 years. We still don't have a clear pathway to a vaccine. So we're up to that, but we wait for it to be. All right.
Launching the poll. Okay. So we can have people answer those questions again after the talk to see if there are any changes in what we are thinking. Okay, so which of the following is not true? 1 out of 12 people in the network feel that D is not true. So you can just run us through.
So which one are we on? Polling question number 1 now?
We started with 3.
We started with 3. Okay, so apologies if this question was a bit confusing. So I think we know that PrEP does not protect against pregnancy. That is true. Only barrier methods or birth control do that. PrEP does not protect against other STIs such as syphilis and gonorrhea. So I think that is key. That people still have to protect themselves from other STIs. PrEP takes 21 days to be fully protective. That's true as well. We've gone over that. An individual on PrEP does not need to have any reviews. That is not true. They need to be reviewed at least at month 1 and then every 3 months thereafter to ensure they don't seroconvert due to poor adherence. Okay, next one.
Number 2, a young woman.
So polling question number 2, this is a young man who has sexual partners and does not use condoms, comes in for PrEP initiation. What labs are indicated? So I think everyone got this, so that it's D, we need an HIV test to make sure he's HIV negative, serum creatinine to make sure he doesn't have CKD, chronic kidney disease, ALT to check his liver, RPR to make sure he doesn't have syphilis. That's just because he's a high-risk person. So we screen him, we take that opportunity to screen him. And then we check for hepatitis B because it will affect his long-term treatment course on PrEP.
Okay, I guess you made up for that one because there's 100% response there to the correct answer.
Great.
Yeah.
And then going back to polling question 1. So this was discussing a pregnant woman who comes to clinic for her first ANC visit who's negative, but she's worried that her partner may be positive and he refuses to wear condoms. What options can you provide her? And the correct answer here is education, offer her condoms, and you can offer her PrEP. Doesn't mean she has to go on it, but you can discuss it with her as an option to protect her if she's concerned about her partner being positive. And that specific situation is in the guidelines, so she would be a candidate for PrEP.
Oh, thank you very much for that, but I guess have your thank you.
Okay, so thank you, everyone. This includes thank you for the Lusaka PHO, because this is where we did the first pilot trial of PrEP at Railway Clinic, and also thank you to the MOH. We've been, Maryland has been working here as an implementing partner of the Ministry of Health, working with MOH clinics for 15 years. Thanks to our CDC, our funder, of course, all the University of Maryland staff, but most importantly, the healthcare workers and all the clinics that have supported clients on PrEP, and all of you out there today, and then our clients themselves who have gone on PrEP and provided us with valuable information about how this is taken up in Zambia. I'll just say a quick word here. We did some pilot trials of PrEP since 2017 in Zambia, and we have, there's a lot of interest and a lot of uptake from serodiscordant couples and also some of the key populations we discussed. But there is a rapid drop-off. So people tend to come and take it for the first month, and then after they take it for about a month, they realize this is actually kind of, they have to take it, they only get the protection while they're taking it, and they get less interested in it. I think people initially thought that, oh, it's a pill I take one time and protected for HIV for my life. And that's not true. It's only when you take the pill every day you get protected. So I think as information about PrEP and better understanding came out into the community, retention has improved. So I've included some references here, of course, the Zambia guidelines, and there's several articles that I've put here. And I've just shared with Madame Nonsa a very interesting recent article written by Dr. Fauci, the director of the National Institute for AIDS at the NIH, and so that will be shared with the network after the talk. And so now, and my contact details are listed there, so we can take any questions as well.
We can take any comments, any questions. As we are doing that, Precious, may you please prepare to do it. If you have difficulties, we will share our screen. So we will take some comments or questions from the network. Are there any comments? But I have a question. Chilenje, please go ahead. Donoya and Tim.
Thank you, Dr. Sombo. I've got a question. We've heard that for the PrEP to be effective, 7 days and 21 days to women.
Move a bit closer to the microphone, Dr. Onoya. I'm so sorry about that.
Yeah, I don't know if you are able to hear me now.
Very well, crystal clear.
Okay. I was saying that we've heard that it takes 7 days for the PrEP to be effective in men and 21 days in women. And reasons have been given, though they don't convince me why. Because in case of other infection, the duration of the treatment, in case of other STI, the duration of the treatment doesn't differ in terms of sex, men or women. We know that we have the same duration for men and for women. How come for the PrEP, there is that difference? For women, it takes long, it's longer for the PrEP to be effective.
Thank you, Judith.
No, I want to take another question.
Yeah.
So Nangongwe, please go ahead with your question so that Dr. Cassidy can handle both of them.
Good afternoon.
Good afternoon.
Yeah, my question really is much more to do with healthcare providers. We have observed that when we talk about PrEP, we have concentrated much of our energies on people that are basically involved into sex or so to speak. We have providers, especially those that are involved in surgical ways. Would it be a good idea that we equally also encourage them to go on PrEP, knowing for sure that they are oftentimes exposed to blood and all such kind of things?
Okay, thank you very much, Kafiwe. I'm going to mute you now. We have a lot of feedback. So there are two questions. The first question is why should, please, may the network mute all the microphones. We are getting a lot of noise here. So the first question from Dr. Onoya was, why is the duration for PrEP before it takes action in women 21 days, while it's only 7 days for men? Because we don't seem to receive any such instructions for other drugs. The second question from Kafiwe was, we are getting some noise in the hub. Somebody hasn't muted their microphone. Okay, that was Dr. Estelle. So anyway, the second question from Kafiwe was, for surgeons and people that work on big procedures, laparotomies, why can't we just put them on PrEP, since they're all at risk from getting HIV when they prick themselves?
All right, thank you so much. Excellent questions, very interesting. So I'll do the gender one first. Yeah, it is very interesting. I think the doctor raises a good point. In other diseases, we don't normally differentiate treatment courses by gender. And really this goes back to the mechanism of how PrEP works. So PrEP provides delivers the ARVs right to the mucosal tissue where HIV gets transmitted. So during acute HIV infection, two mucous membranes come into contact with each other. In the case of heterosexual sex, usually that is the penis and the skin on the penis coming in contact with the vaginal mucosa. So the mucous membranes on the penis are directly fed by the blood supply, and so have full concentrations of tenofovir, of the drug, coming directly to those mucous membranes. So it only takes 7 days to reach effective levels there. In the case of the vaginal mucosa, the blood supply does not directly feed the vaginal mucosa. It's a bit filtered. There's a two-step procedure for that blood to get there. So that means that tenofovir levels fall off along the way to the vaginal mucosa. So in order to reach fully protective levels of drug in the vaginal mucosa, it actually takes 21 days to get to that fully protective level. So it's a function of physiology and the area of where we're trying to deliver the drug to. That's why it takes more time for the drug to get there in that case. Then the second question is around the surgeons. That's a very interesting question. In general, that's not a standard recommendation to provide healthcare workers with PrEP. However, normally we expect that healthcare workers are taking adequate precautions to protect themselves against PrEP, against HIV acquisition. So, gloving or even double gloving, and being very cautious with sharps and so forth. So there shouldn't routinely be needle pricks and accidental exposures. And also clearly PEP, post-exposure prophylaxis, has a very strong role to play in healthcare worker exposure, where after a needle stick or an accident during surgery, such as a nick with a scalpel, one would take PEP thereafter. However, if you were in a situation, and then the flip side of that is that for all elective surgeries, patients who are HIV positive ideally should be, taking their HIV medicines and be well controlled before going into surgery anyways. So generally it would not be a recommendation for a healthcare worker because we have other avenues to minimize their risk. If someone was working in somehow an area where there was no HIV treatment available, so everyone had uncontrolled viral loads, and there were no gloves or other resources available to prevent against needle sticks and accidental exposures, then I suppose it would be something to consider. But generally, we have other ways in which we can reduce that risk.
Okay.
Dr. Felicia, do you want to add anything?
Well, not really, just about TAF and PrEP, because that's also one of the reasons, isn't it? Because we are not getting enough concentration of TAF in the vaginal mucosa. That's why we are not using TAF. Mm-hmm. For PrEP, I know in Zambia we're getting TAF-Ed, so TAF will be on the market. So for now, it's just tenofovir, because we know that levels of tenofovir will be high in the cervix, in the vaginal mucosa, and everywhere else where you need it to be high. So Chadiza, you can go ahead with your question. Your hand is up, Dr. Matua.
Good afternoon, Doctor.
Hi.
Our question is that the regimen for PrEP, it is TDF and XTC. Which alternative treatment do we have in case the patient is not tolerating that regimen, or if the patient has renal failure? Which alternative can you use? This is not mentioned.
What's the alternative to TDF and XTC? I know I got a phone call where a man had renal dysfunction, creatinine clearance was less than 30. So are there any alternatives to PrEP for now? Are there any other drugs that have been studied?
Yeah, so the short answer is no. There's no other drug that has been studied. So for for better or for worse, so tenofovir and FTC has some attractive components that made them the lead candidates for PrEP. They're once a day, and as Dr. Faloshi was explaining, they reach very high levels in the tissue. So other drugs such as abacavir or AZT have not been studied in the role of PrEP, so we don't know how well they work. And also we also have concerns about the way the pharmacology of those drugs, that they may not be as effective for PrEP. So for now, all I can say is I would not if someone doesn't meet criteria for PrEP, I would not recommend that they go on PrEP, because the drug we have is the only one that's been shown to be effective.
Okay, I hope that's helpful, Dr. Matua. Mary Boyd, please go ahead with your question.
Hi, thanks so much for that amazing presentation. A question that I had was, where can the network find either the printed guidelines or soft copy guidelines so that they can, refer to it in the future? Or is this something that will eventually be part of the ZCG? Is that conversation happening, or is it a separate guideline set altogether?
Yeah, thank you, Dr. Boyd. No, the information I'm presenting is part of the ZCG 2018 guidelines. It was presented at the conference in December 2017, and when those were distributed, and so we had PrEP in the guidelines in 2016. At that time, it was only for serodiscordant couples and for pregnant women. Then in over the 2 years, 2016 to 2018, the National PrEP Task Force met and expanded guidelines to all people at significant risk. And this is as part of the guidelines. So it's on the guidelines app and on the soft copy available on the website and in the printed materials. So I hope all the clinics do have, and all the network does have access to those materials.
Yeah, so in summary, it is in the guidelines. So yeah, everybody should have access to the guidelines. Mongo Auburn, Precious.
Yes, Dr. Faloshi.
Please go ahead with your presentation.
Good afternoon, everyone. Presenting to you, I'm Precious Hatimbula from Mongu. I'm Nurse Mentor. The facility presenting is Mongu Urban Clinic. We'll go ahead with the case. We are presenting to you a male 35 years old who is HIV negative. He has had sexual relationships in the past and has never been married. He accompanied his girlfriend for enhanced adherence counseling visit in December 2018 following a high viral load. She has been on ART for 2 years, which she started in 2016. Initially, she was on tenofovir efavirenz, but was switched to AZT3TC lopinavir in May 2018 as a viral load was still very high. They have been in a relationship since September 2018, and they have had regular sexual intercourse, and they have not been using condoms. Despite the counseling, he has chosen not to use condoms. Repeat HIV test in December revealed he was HIV negative. PrEP, which is tenofovir, was initiated at the same visit in December, and the girlfriend's viral load was collected on the same day in December, which has showed that she has now virologically suppressed. On physical examination for the female who is on ART, she appears well and healthy. Her temperature was 35.3 degrees Celsius. Blood pressure was 101/68. Weight was 43. Respiration was 18. The partner who is now on PrEP also appears to be well and healthy. His temperature at the time was 36. Blood pressure was 120/68. He weighs 67 kgs. Respiration was 18. So the available results that we have for the HIV positive client, in summary, was that in 2016, she tested positive and was put on treatment. which is TLE. Then in June 2018, her viral load was collected. The results came in May, and the results for the viral load was 68,118. And at that time, she was switched to AZT3TC lopinavir. In October 2018, a viral load was done again, and the results came in December. And the results still revealed a high viral load, which was 41,148. And enhanced adherence counseling was continued. And AZT3TC lopinavir was also continued. In December 2018, when she came, another viral load was done, and the results have came in January 2019, of which the results are 294 copies. Then action was to continue the AZT3TC and lopinavir with an addition of a weekly pharmacy schedule. RPR in December was done on the female and revealed that it was negative. Creatinine was collected in December, and the results showed that she was at 58. ALT was done also in December, results were at 18. AST was done in December, the results were at 16. For the negative partner who is on PrEP, he tested in December, and with the other tests that he has been doing, in December he tested HIV negative, of which he was started on TDF3TC, and he has continued on TDF3TC. And for his lab investigations, RPR, which was done in December, came out negative. Creatinine was done also was at 85. ALT was at 25, and AST was at 22. Our questions are, since the client on ART is virally suppressed, of which her viral load is at 294 copies per mil, can we now stop the PrEP in her HIV negative partner? That is our first question. Then our second question is, does PrEP alone take away the need for condom use in prevention of HIV transmission? Thank you very much.
Thank you very much, Precious, for that. That was very clear. I feel like I don't need to summarize, but nevertheless, I will. Essentially presenting a 35-year-old male who's HIV negative, currently on PrEP, with an HIV positive partner, previously known to be non-adherent to therapy, as evidenced by high viral loads reaching the thousands. However, partner is now adherent and has a viral load of 296, which is less than 1,000, hence suppressed. Partner who is HIV negative refuses to use condoms and seems adherent to the PrEP. Their question is, can they now stop PrEP? Before we go into that, I'll take some questions or comments from the network. Any questions for Precious, anything you'd like to find out? Essentially, both lab results are fine. The kidneys are fine. The liver is fine. They don't have syphilis. We don't know if they have hepatitis B because it wasn't done. Any comment for Precious? Oh, Precious, you can stop sharing. We'll share from our end if we need to go back. So I'll take any comments or any thoughts on this case before I come to the hub. Just a second, sorry. I'll start with the network. Okay. Dr. Tembo, would you like to say something? From Katete, St. Francis. Just wait, I can't seem to unmute it. I just try to unmute Dr. Tembo.
What name is it?
It's Dr. Tembo, Katete. I don't know if I'm still a cohort. Okay. Yes, Dr. Tembo, please go ahead. Sorry, I'll come back. I was
trying to find out how long this negative partner has been on PrEP from the time that the other positive partner had a viral load. And what is the whole big deal for him not to agree with condoms? What are his basic reasons?
Precious, did you hear that?
Yes, I got him loud and clear. So how long he has been on earth was, he came on the 17th of December, 2018. That is the time we initiated the PrEP, of which the client who was being escorted, the HIV positive client, had a reading of 41,118 viral load, which was collected in October. But like there was no action that was done as soon as the results came. I'm not so sure when the results came in. So that's why the man was captured at that point when he was escorting the partner. Then the basic reasons as to why he's actually declining the condoms, he just openly said, I don't use condoms. I don't need them. I don't feel it when I'm with my partner. That is what he explained to me.
Okay, I hope that's graphic enough for you, Dr. Tembo. So it seems it's been on PrEP for actually a month. At that point, they had just seen the very high viral load. I know Livingstone has raised a hand. Please go ahead with your comment or your question to Precious. Please unmute them. Oh, hi, Robert. Please go ahead.
Good afternoon.
Good afternoon.
Hello,
Yeah,
good afternoon.
We have a sound issue.
Yeah, sure.
I'm so. Oh yeah, go ahead.
We have a question here. Though one of them is a concern. We don't know how this patient, how the female ended up being switched from first line to second line. We don't know if that was through resistance, and if so, we don't know if the procedure of enhanced adherence counseling was actually done before the switch to second line. And this comes up with, this brings a follow-up question. Looking at the female having failed an offer-based regimen, and that's the one that the boyfriend is actually taking as PrEP, TDF, and XTC or 3TC. Is there a possibility of transmitted resistance in this case, looking at the two regimens and the issues of resistance that we're talking about here?
Okay, thank you so much, Robert, for those observations. I think Chilenge, please go ahead with your question. Thanks, Robert. I'm sure that has been noted.
Is this man circumcised?
Okay, wow, Precious. There's a question for you. Is this man circumcised? Did you check?
No, I did not check, but it says he is circumcised.
Okay, thank you very much. I'll let you take one question that came from Robert. The other one I'll leave for Dr. Cassidy because it's a bit too ID. The question is, what do you think of the way the switch was done in May 2018 with a viral load of 68,118? Do you think it was true failure or maybe our switch was immature? Was enhanced adherence counseling done? Should we have switched with one viral load?
Okay, the client before had two high viral load results, of which I think the clinicians that were seeing the client at that time may have missed the understanding of doing enhanced adherence counseling. So truly speaking, the switch, it may not have been rightfully done. We can accept. Yes.
Okay, thank you. Precious, I think I'll leave that to Dr. Zico. I know we have a question or a comment here from the hub. Please, you can go ahead.
Well, it was me, but I think that Livingston has already...
Okay. So is it about the transmitted resistance?
Yes.
Okay, so...
It was about actually the switch that TLE to AZT, and then the person who was giving the prep ended up using VADA, which was a switch before. So I wanted to find out whether that was possible.
Okay, so I think the question, this is a hard one, I think, because we've just been told by Dr. Cassidy, the only drugs that have been tested are your Truvadas, your TDFs, your FTCs. What do you do in such a situation when there's risk of transmitted resistance? I don't know if you want to comment, or Dr. Mwemba, on this issue.
Do you want me to talk now? Or Dr. Mwemba or the panel? Me? Okay, on both issues?
Both.
Okay, so thank you so much, patients. This is a fantastic case, very interesting, and there's a lot of nuances here that we get to unpack. So I think the question is about prevention of HIV in serodiscordant couples. Is the sort of the topic as a whole, right? There's a couple here. The lady has HIV, and the male partner does not. So what are the methods that we have available to help them stay that way to prevent him from getting HIV? So there's really three key components. One is condoms, which he has told us he is completely unwilling to utilize. Then there is PrEP, which we'll talk a bit more about. And along with PrEP, you can enhance the efficacy of PrEP by using male circumcision. I think that was already discussed, so that was a good point. And then also the idea of obtaining an undetectable viral load. And this, what we talked already about, undetectable equals untransmittable. So the first question is, can I stop taking PrEP if my partner is fully suppressed? That was the question. And so there's actually two questions here, and there's a difference between suppression and undetectable viral load. And so in Zambia, we define viral suppression as under 1,000 copies per mil. And so yes, by our Zambia definition, she is virally suppressed. However, I want to point out that she only had one viral load done, and it was under 1,000, but it was 294. So yes, she's virally suppressed at one point. However, she does not meet criteria for undetectable viral load. So those criteria in all of the studies showed a viral load of under 200 copies per milliliters and over 6 months duration. So if she has 2 points in time where her viral load is under 200 and those 2 points in time are over 6 months, then at that point in time she would be considered undetectable and would not be at risk for transmitting the virus. How confident are we in saying that she would not transmit? Well, in all these trials, they had over 400, the result of the Partner 2 trial was that you would have to have sex for 400 years without a condom continuously to transmit the virus one time. So it's very robust data. And there have been 4 very, very strong trials that have shown that when you are fully undetectable, you do not transmit the virus. But this lady, though she has 1 point of viral suppression, she is not yet undetectable. So at the time that she becomes undetectable, she would then, at that point, would not transmit the virus. The other key aspect of this, I would point out, is that it requires a lot of trust in your partner. So from the man's perspective, he needs to be confident that the partner is going to continue taking the ARVs and maintain an undetectable viral load so that he is protected. Then the second question, which is also very fascinating in this case, is can the male partner now stop using condoms if he's on PrEP? And the answer to that question is it depends. There are several questions to consider, right? So first of all, as we discussed, condoms protect against a number of things that PrEP does not. It protects against syphilis, gonorrhea, chlamydia, and all the other STIs. It also protects against pregnancy. So it sounds like to me this couple may be trying to get pregnant or at least aren't concerned about it. So, those there are other benefits to condom use, and those need to be explained first and foremost. Then the question is, so assuming that they're not going to use condoms, what's his risk? Well, in general, we say that PrEP in the trials is up to 92% effective, but efficacious. But what's fascinating about PrEP is that the results in real life are actually better than in the trials. In trials, people don't have perfect adherence, but actually in real life, when people know that this is protecting them, they actually tend to have much better adherence. So in the real world, when people are 100% adherent to PrEP, what actually happens? Well, now we've put hundreds and hundreds of thousands of people on PrEP. It's currently estimated that somewhere between nearly 1 million people on PrEP in the world. And to date, there have been 6 cases of documented transmission while on PrEP while actually fully adherent. So that's better than 99%, that's 99.99% effectiveness in the real world. But let's talk about those 6 cases because we're always worried about something going wrong. In each of those cases, someone who was taking their PrEP properly, they were fully adherent. How do we know? They took hair samples and proved that there were drug levels in them that were consistent with daily adherence. And they got the virus despite that. How did they get the virus? Well, the virus was a resistant virus. So it was a case of transmitted resistance. And so it was a virus that had already been exposed to tenofovir and FTC and had mutations that allowed it to evade those drugs. That was true in 5 of the 6 cases. The 6th one was a special case that we won't go into here. So in that case, so in these cases of transmit, and several people have raised a concern for transmitted resistance, which I think is very valid in this case. So the lady was on TLE, so she was on Atripla or tenofovir, FTC, and efavirenz, and for one reason or another, she did not suppress on that. Maybe she wasn't taking the medicine properly, and she was poorly adherent, or she already had resistance at the time. One way or another, she's at significant risk for having a K65R mutation and a 184V mutation, which would create a resistant virus that we would be able to evade PrEP and get around it. So there are several concerns in this case. So the patient, while the guy is on PrEP, it may not be a full defense against her because she may have transmitted resistance. And while the lady meets Zambian criteria for viral suppression, she does not meet the standards for undetectable virus. So what I would recommend in this couple is that you work with the lady to make sure she reaches an undetectable viral load. That's defined as under 200 copies at 6 months apart. And at that point in time, you could counsel them to at that point she is not at risk of transmitting the virus. Generally, in these cases, what I recommend to people is that there are 3 options for protection: condoms, PrEP, and undetectable viral load. And each one is very good on its own. And if they want to be 100% sure, they can use 2 at a time. So that's condoms and partner on ART, or PrEP and condoms, or so forth. That means that if someone messes up and doesn't take their medication one day, so if she's on PrEP, if he's on PrEP and she's on ART, if they forget one day, then they'll still likely be covered. But in general, in terms of the science says once she's undetected and she continues to take her medicine properly, she will not transmit the virus. And at that point, he can come off PrEP and they're free to engage in their condomless sex for as long as they want.
Okay, thank you. Thank you very much. I was looking to ask Dr. Zico this question. I don't know what your opinion is, because I know in the partners 052 and HTN 052, when they found that people got HIV, when they were the discordant couples, it was actually unlinked. And these people are also more likely to have STIs. And the situation you are describing, he's had several partners. We don't know how many other partners he has. So he may not need PrEP, maybe even from her, but from his other partners, because they found among people who are discordant, the new infections actually come from outside that relationship. So I think that's something to think about. I know Dr. Mpeta, your hand has been up for a very long time. I'm so sorry about that. Dr. Mpeta, please go ahead.
Yes, I think I concur with Dr. Claassen about this patient. Sorry, it's noisy, it's raining where I am. First of all, this patient, we have to look at the fact that number one, she is coming from a very high viral load. And if we look at the rate at which the viral load is dropping, you know, it's a bit questionable if this woman has been very adherent. So one of the things that we should notice is that the guidelines needs to be somehow cleared on the fact that is it one viral load or is it you know, sustained viral suppression, which is at least 6 months apart, not just one reading. If we could do actually one or two readings or more, then we can be comfortable that this woman is, you know, stable and virally suppressed, rather than basing on one reading of which this woman can actually, you know, go back into viremia anytime. So I would not be very comfortable to stop the PrEP based on one reading because looking at the patient profile, I'm not just convinced that this woman is quite very adherent to treatment, and we really need her to be stable for us to you know, advise the man to stop the PrEP. I hope you are able to get me, Dr. Somo.
I'm so sorry, Dr. Mpeta, but you can type it out because we are in the same building. So your problem is our problem. But I'll try to.
I noticed it's quite noisy. I'm going to type.
Okay, yes, because essentially you are just agreeing with Dr. Cassidy that we need to have a sustained viral load before we can say that you are actually, U is equal to U, and then you can stop your PrEP, which goes back, and this is why I love these cases, because when we go back to our guidelines, this is something that we need to look and make very, very clear in our guidelines. For Dr. Zico, what's your...
Just to add, Dr. Mpeta was also commenting in the trials that people did get HIV, but they were outside of those couples. Dr. Floshi was commenting on that too. So this is a good reason for this gentleman perhaps to remain on PrEP if he's going to be working outside of this relationship with other ladies as well.
Yes, Precious, are you with us? If he's going to be working outside of this relationship, you may need to also engage his other relationship so that he's aware that he will still get HIV from other partners. For Dr. Zico, I think there was another concern about the viral loads, that we only had one high viral load and then we had a switch. When we talked with Precious, one of our questions was, can we go back to TLE because we think she may have been adherent? What are your thoughts about that and the risk of that transmitted resistance? Can they go back to TLE? How easy is it to change a decision like that when it has been made in clinical practice?
So I think with the decision that was made, it's quite difficult to go back unless you have a genotype. So without a genotype, I would recommend the continuation of the same regimen that was that the patient was switched to.
Okay, thank you very much. I know we have Dr. Mundia, who has a lot of clinical experience in PrEP. She's our own expert there at AIDC. My question is, have you seen any people seroconvert while on PrEP? Because I know you test your clients every 3 months. Have you seen any seroconversion? I mean, what type of situation? What should we be looking out for?
Thank you, Dr. Faloshi. We've had a few seroconversions. I think about 2. These were in the groups of the MSMs. All the seroconversions were due to poor adherence. So what we've done as a team at AIDC is to reinforce adherence in each client as they come in at every review for their PrEP. And for those that don't seem to be so sure whether to continue or not, usually we do kick them off PrEP until we're sure that they'll be willing and able to take the PrEP.
Okay, thank you very much, Dr. Mundia. I'm so sorry, we have a lot of rain. I hope people can hear us. But there's a question here that is saying, what are the options for somebody who has renal dysfunction and hepatitis B in terms of PrEP?
I'll let the expert in the corner there answer that one.
Dr. Mwemba, that's for you. I know I was in the clinic today, and we had a lot of hepatitis B with renal dysfunction. And now we transition those to TLD. But for now, I am HIV negative. I want PrEP, but I have hepatitis B as well. I know it's a difficult one.
I think that's a very difficult question. But having said that, is that you can't hear me?
Sorry.
Can you hear me now? I'm much better. So what I was saying was that in a CKD patient, I think there are certain factors that you need to take into account. First is that CKD itself gives you reduced libido. And therefore, the amount of sexual partners that you're going to have is going to be reduced. And therefore, likely you're going to stick to your only partner. I think that's what I need to emphasize here. That's the first point, that CKD patients usually are treated for reduced libido because of the issues of imbalance in hormones and things like that. Secondly is that the problem is that there's no real study that has been done on CKD and PrEP. And so even if you were to prescribe, is that we have no reference to make that PrEP can still work. But having said that, is that we do adjust TDF even in CKD patients, as long as you're sure that the cause of the renal disease was not the TDF. So I have patients that are on TDF once per week, because I think that the TDF is going to be beneficial to the patient. So we do make such decisions on an individual basis. Whether that can prevent HIV transmission, I cannot answer that.
Yeah, just to follow up on Dr. Mwemba's point, that the dosing of tenofovir in CKD patients for treatment of HIV or treatment of hepatitis B is a very different thing than dosing for protective levels to prevent acquisition of HIV. And the two are very not the same. So though we may use tenofovir in CKD patients for treatment, we don't have any evidence to show that kind of dosing would be effective for prophylaxis.
Okay, so it's something that you can consider, but it has no scientific basis. So this study hasn't been done. Maybe it's also because of issues of libido on people with CKD, so there hasn't been demand for it. So I must say I got a call from Western on the same issue. I was completely blank. I said for now, let him hold off until I get the answer. But now we have the answer. There's a question here, I think, Dr. Mundia, what registers and screening tools are available for clients on PrEP? We have registers. Is there a way of monitoring? What's the data? How are you managing the data side of your program?
We don't have a PrEP register yet available here at UTH, no, but I think there should be one which has been worked on, but we just haven't yet received it here. In terms of the tools, we do have PrEP initial forms and follow-up forms that we use, and there's a guidance on those forms that people can easily follow up in terms of screening the patients. I think Dr. Cassidy, is anything?
Yeah, so we've worked with MOH to create PrEP initial history and PrEP follow-up forms, and those, as Dr. Mundia is talking, are in circulation, and there is a PrEP register, and we'll make sure that UTH gets one that tracks the patient across time and make sure that they get the right lab tests at each visit and documentation of their negative status before they go on.
So thank you very much for that. So Precious, I hope you are still with us. Unfortunately, you don't have video on. So in summary, this gentleman, for our lady and our gentleman, the gentleman needs to stay on PrEP because we don't have evidence of persistent viral load suppression. I would actually be very cautious in a person that failed to take one tablet. I would watch this patient very, very closely. So we need to get to less than 200 over 6 months, meaning you need 2 viral loads to say, okay, you are suppressed. And we need to remember and tell our client that condoms do not protect you against pregnancies and STIs. So for this client, we need to continue using condoms. And there is also that risk of transmitted resistance. Remember, she failed TLE. So if any virus she transmit will actually be resistant. Either if she spikes, she will transmit this virus. I don't know, what's your comment on this, Precious? I hope that was helpful. Was it helpful?
Yeah, it was really, really helpful because I think I've drawn more than 10 points from our discussion. Thank you so much, Dr. Claassen and everybody.
Yeah, no, thank you so much to you. That was a great case, a lot of new ones. And as Mary Boyd was saying, where can people find this resource? One of these resources is HIV Insights, but we'll put up Dr. Cassidy's PowerPoint on Slack. A lot of us are not using Slack, but we'll put it up. And when we go back to our guidelines, this is something we'll look at very closely so that it's very clear to everyone that we need at least 2 viral loads less than 200 before we say your U is equal to U. Any comment, Dr. Cassidy?
Yeah, first of all, patients, thank you for the excellent case. As Dr. Feloshi said, there are lots of really interesting subtleties there that we got to pick apart. As I said, there's a recent article from Dr. Fauci and his team that summarizes all the evidence that goes into UE equals U. That was just published about 3 weeks ago. So I've shared that with NOMSA, and I've asked her to distribute the article to the network team after this lecture. So something for you all to read on the evidence behind U equals U. And yeah, thank you so much. It's been a privilege to be part of this today.
Yeah, we've loved having you. Any comment, Dr. Mwemba, on bone mineral density and the use of TDF? Because I know aside renal dysfunction, there are issues of bone mineral density. Should I take PrEP and lose all my bones? Any data on that?
Dr. Sombo, each time that I'm coming here, she's asking me another question. When but anyway, I always say that even for the nurses, wherever we are, is that every patient that you do a height every year. Because if you're on TDF, there's a small risk that it might reduce your bone density. Obviously, I think that it's more in those that are elderly, those that are taking probably alcohol, and another drug that can worsen your bone, or another comorbidity like CKD. So those patients will need more monitoring than an older person that is around middle age. And also in children, it is very important because TDF does cause that. And probably for African children, we are going to discover, because part of my PhD is to do bone mineral densities and CKD in adolescents. And so maybe we'll answer that question for the Zambians. But my initial one was that actually why I came back here was to just find out whether it would be important that we do a genotype in this patient. If we can...
Is that for you, Dr. Cassidy? Because our viral load is 264, unless we did ultrasound. So at this point...
Oh, it's only 200.
Unless it was more than 1,000. Unfortunately, we can't amplify. So what I came across for bone mineral density is that for those that had taken PrEP for a year and a half, they did some studies. They found that actually they do lose it, but they get it back. So I don't know, but they haven't done long-term studies the way
it's the same in children. Yeah, so same in children. Even children that you lose it initially, just like the creatinine, it goes down initially, and then later on it just stabilizes. Okay. So, but I always say that there are people that are prone. I have a nurse who was just a nurse in my whatever, and she had to go out to undergo a spinal surgery just because she had minimal bone density disorder, and so it can happen. And this is a patient who had no kidney disease at all, and so it can happen. It can be rare, but it does happen.
I must say, PrEP is one of those things in science that's just amazing. Who thought we'd reach this point in HIV where you can be HIV negative and stay negative even if you sleep with someone who's positive? I think it's amazing. The breakthrough in science. I think we are getting closer to the cure. NOMSA.
The other last point I wanted to make is that you asked me a question on Hep B and CKD. So we'll be receiving a cover for those that really need it. And so for Hep B, so you might not need to use a TDF, but you'll be using entecavir. And so probably it will be coming in time this year.
But entecavir has no effect against HIV.
Well, so usually the problem is that when you're switching from TDF to another drug, so you might need to add entecavir and then you switch the other 3 drugs.
Especially in your clinic, isn't it?
Yeah.
So we have some news on the CPDs.
So thank you all of you for participating, and I'm sure that we are benefiting from this session. And you'll also agree with me that really this is part of continuing professional development. And we have our skills and knowledge updated as we participate in these sessions. But we also wanted to enhance that if you are to attribute this to your CPD points, we need to have a form of verifying. And one of our ways we can verify that you participate in these sessions and you can attribute this to your CPD points is to register. So I would like to encourage the network that as you walk in whichever space you are participating from, please register immediately, and would like to receive those registers soon after the session. And this includes the hub. Thank you so much.
Thank you so much, Nomsa. So next week we are talking about switching between regime, HIV treatment failure. We have Dr. Lothi Achambo, and I think we have Dr. Mpeta and Dr. Nyaku joining us. Thank you so much. See you next week on Monday at 2:30. Thank you, Dr. Cassidy, once again.
Thank you so much.
It's a wrap.